Instructor Howard, and we are going to be breaking down coding cases for BC3030 Week 2. Welcome back. Remember, you'll need a copy of your coding exam, your ICD-10 manual, and your CPT, and something to take notes with. Additionally, if you have not done this already, please be sure to review the Getting Organized Before Learning Coding video. As always, the videos will be loaded inside of your weekly materials folders, but you can always right-click, copy the URL, and paste it in a different browser to view this information in YouTube for a bigger, larger screen. Okay, so this week we're covering respiratory coding guidelines as well as respiratory coding. We're dealing with the respiratory system. If you haven't done this already, please be sure to download a diagram of the respiratory system, or you can look at the diagram and download a copy of what I've saved inside of Week 2 Student Materials folder. You will also need a medical dictionary, and you will also need to set aside enough time to go through this case in its entirety. You want to get started as early as possible in the week so that you can complete this exam on time and get your full understanding. Remember, there's just the general respiratory coding guidelines video that covers Chapter 9 in your Week 2 Student Materials folder. You want to review that as well, just so that you can have a full understanding of everything associated with the respiratory system. Okay, so let's get started. Okay, so what I have in front of me is a copy of your Week 2 coding exam. It's going to download in a Word document. And remember, you always want to click the area at the top, right-click, and choose Remove Content Control. This way, you'll be able to highlight different portions of the case and get a full understanding of your scenario. You can also type in here, so if you want to jot down some notes, you can do that as well on this actual test. Okay, so first and foremost, where's the services located? Outpatient hospital. Always want to pay attention to your headings. The attending physician and the surgeon are one and the same, so this is who's treating the patient. And sometimes this matters when you're inpatient versus outpatient. When you're dealing with some diagnostic tests, you may have to code one for the facility, TC modifier, one for the physician with a professional component. But that's not going to be done here today. That's just a reminder of different things, why we need to know where and who. Okay, so we have our preoperative diagnosis: left true vocal cord mass, hoarseness, asthma, gastroesophageal reflux disease. These are all the problems that the patient has, either chronic conditions or reasoning for the services for today. Gastroesophageal reflux disease is probably a condition that has appeared due to whatever's going on with the vocal cords, and we'll get into that a little bit later. Asthma is a chronic condition. Okay, so these are just your preoperative. Remember, you always have to go through the case and determine what the outcome of the operation is, or the diagnostic test, to determine if we're going to keep these diagnoses or if we're going to trash them. I'm going to say trash them, meaning not use them and not code them. Okay, so postoperative diagnoses are one and the same as preoperative. I usually suggest pulling all of the diagnosis here from your postoperative diagnosis, because it usually changes. And in this scenario, I'm not sure that this is going to be one and the same here. So we're going to review the case to determine if the report is accurate. I don't think the report is, but let's go through it. Okay, so we've discussed tidbit about the diagnosis. Now we're going to get into the procedure or the operation. So this says, this has like a typo in here. This is operative performed. This should be procedure performed. So I'm going to change this so that it can make sense to me, or else I'm going to go crazy here. Okay. Procedure performed. What they did is a direct laryngoscopy with use of operating microscope for excision of a left anterior true vocal cord mass. That's a mouthful. So what he did was he pretty much looked inside of the larynx using a microscope that they use for operating purposes. They cut off a piece of the anterior, which is the front portion of the vocal cord. It's a mass, so they cut a portion of that off. Excision means to cut and take out. Okay, so that's how we put it in layman's terms. So your indications. Your indications is a different area of the report where you can pull some additional diagnosis, or if this were an E&M case, this will probably be considered the history of present illness. So here are the reasons or the indications, the reasons why this service had to be rendered today. He's 65-year-old, has chronic hoarseness, long-term history of tobacco use, and he quit smoking 2 years ago. His examination from probably a previous visit revealed a mass or a growth or neoplasm or tumor. I want to say, I'm going to call this neoplasm for my diagnosis purposes. It's just a new growth. I'm just adding that in here. A mass could be anything, but when we're dealing with diagnosis coding, it's best to stick with the terms associated with what we're going to be coding from the book. Okay, so the anterior portion of the left true vocal cord. Left true vocal cord is where it is, left and right. Sometimes with ICD-10 coding, the coding has to be chosen based on either left or right. Not sure if this is going to be significant, but I highlighted that just in case. He has a history of asthma and reflux disease. We know that. Those are listed here. Okay, so this case is really fun. It's a lot to take in, but it's really simple. So, procedure. A lot of this information in here really does not have to be reviewed. It's just going to give you some more detail about how they actually rendered the service. Here it's telling us that he did the laryngoscopy, but he also, with an excision. But here it also tells us that he used forceps and micro scissors and he cut the mass. So that's highlighted. He actually, it's up here. This is the short description of the procedure. This is the long description of the procedure. Any other things in here that we may need to pick up, such as if there were complications, if there's a modifier, for example, 2 surgeons and things like that, then we'll have to probably pull that out of here. So he's, I'm just going to get into some of the stuff that I'm reading, just so that you guys can understand that reading these reports are very fun because you get to learn a lot. So it's talking about he's in the operating room, placed on the table in a supine position, and that's laying face up. The patient had general endotracheal anesthesia. We are not coding for the anesthesiologist, so this does not matter. But what they did was they put a tube down his trachea and pushed in anesthesia gases to put him to sleep that way. Okay, so the patient was positioned for direct laryngoscopy, and direct is basically using a scope and looking at the actual larynx and not using a laryngoscopic mirror. The mirror that the provider has at the doctor's office, where he says, open your mouth, and he looks inside, that's an indirect laryngoscopy. This one, because they used in a microscope, it made it a direct laryngoscopy. Okay, so the laryngoscope was placed in position and there were no lesions on the oropharynx or the hypopharynx. Now, when you look at your diagram, you're going to see that the larynx goes down through, the pharynx, and all of that connects down to your respiratory system, which goes off into your lungs and your bronchial tubes and things like that. And so it's kind of broken up into different portions. So that's why the oropharynx is the portion that's right near the mouth, and the hypo is right underneath that, or in the back of the mouth. And then the microscope was then brought in, and then what they did was they looked at the mass. It was noted involving the anterior third of the left true vocal cord, which is the third portion. If you look at like a stick or a tube, it's divided in threes. So let's look at the third portion of it, which is the bottom half. And then you have a vocal cord on the left and right. And then pretty much talking about exactly where it is. And since he sees it, he notates it, he pretty much excised it and cut it. But he didn't just excise it. What he did was he sent it for biopsy. So after he pulled this particular mass from the patient, it doesn't really give us detail about that he sent it for pathology review, but he did. So just kind of cuts down a lot of this unnecessary reading. It just skips to the fact that the pathology report gave us the fact that the patient had adenocarcinoma and primary. It's just saying poorly diffused, and that has nothing to do with our coding. So primary, when we're dealing with neoplasms, and that's why I put neoplasm up here, you have different types. You have primary, you have secondary, you have in situ, you have uncertain behavior, and you have unspecified. So those are various portions on your neoplasm table. Primary means this is the very first growth, or very first part of the body that this particular neoplasm or cancer has appeared in a patient's life. So if the patient had this removed and he was no longer dealing with cancer, and the patient gets cancer somewhere else, or adenocarcinoma in another location, that location will always be considered secondary. And any other locations that the cancer appears on the body will always be considered secondary. So that's the difference between primary and secondary. So now that we've pulled all of this information related to the procedure, laryngoscopy, the diagnosis, we can code. Now, what I was saying here is that the postoperative diagnosis is the same as preoperative. That's no longer true. Right here, the postoperative has now become adenocarcinoma. So I'm going to actually change this because I don't want to code the wrong thing. Carcin. Just didn't look right. Okay, so this is going to be my diagnosis, and this is also known as a neoplasm. Up here, a vocal cord mass, hoarseness, those two, these will not even need to be coded. I'm trashing these because now we have a confirmed diagnosis. I'm also trashing the gastroesophageal reflux disease because the reflux is a sign and symptom or a problem associated with the mass or the adenocarcinoma in the vocal cords. So all of these diagnoses here are pretty much signs and symptoms of a major problem, and this is the problem. So those, I don't have to code them. I have, a confirmed diagnosis. Asthma. Now, this is a chronic condition, But this also does not need to be coded today. So I'm going to cross this off. The reason that asthma is not going to need to be coded today is because it has nothing to do with the services that were rendered today. So the only reason that he did the, laryngoscopy, and you can see it in the indications, is because of all of these problems related to the vocal cords and hoarseness. But now that he has a confirmed diagnosis, we know that asthma does not make any of this happen. So we're not going to code that. We're only going to code the reason for the service, or the main reason for the service or the problem today. Okay, so what else? Long-term history of tobacco. This problem is associated with this problem. And the reason being is because they always say that smoking can cause or may cause cancer. So these are our main two and only diagnoses. So now let's look at what we're going to do as far as our coding. Okay, so I have my electronic coding manual here for give me some speed. I prefer using the book because that's how I like to code, and I like to actually look at and read the guidelines as I go. But to save time today, I am using this manual electronically. Okay, so dealing with our CPT portion first, and I just want to let you know, as always, this side of my electronic book is the output index, whether I'm dealing with CPT or diagnosis. This side over here of my electronic manual is my tabular, and these are the different sections or subsections. So since I'm dealing with CPT, this subsection is my surgery, and my section is my surgery, and my subsection is the respiratory system. Yeah, correct. Okay, so my word laryngoscopy, that is my main search term for today, for my procedure. Now the provider did a diagnostic laryngoscopy, but he also did a direct laryngoscopy. So we're gonna pull the information for the direct laryngoscopy. Now we have several things here. This is operative and this is also direct. Because it said direct, I'm going to look at these codes first in the tabular section to see if I can locate more details related to what happened to the patient. So it says laryngoscopy, my first code that I was, chose or from my range is laryngoscopy 31515 direct with or without tracheoscopy. Now, let's look a little further because we want to be more detailed, as detailed as possible. So what's mentioned in our case is that there was a operative or microscope used. So let's look at all of these to see if they make sense. This code is referencing to foreign body removal. He removed the mass, but it wasn't a foreign body. And then the code indented underneath is the same, but it's just the code with the operative microscope or telescope. So these two codes, or this code, does not apply. Now we have laryngoscopy direct operative with biopsy, and then it says with operating microscope or telescope. Okay, so this code seems to make sense because he did get a biopsy done, but let's look at the other one. Laryngoscopy direct operative with excision of tumor and or stripping of vocal cords or epiglottis. Stripping of vocal cords or epiglottis wasn't mentioned, but it says and or. So anything that says and or is also safe to use. Now we also have the code that's indented underneath this one that says with operating microscope or telescope. So if you want to pay attention to these particular codes, I'm going to highlight them here. Not going to give you the code to choose. I'm going to give you the range. So I have 31530 through 31541. So out of those codes, it's up to you to make a decision on which one actually matches what happened with the patient today. Okay, so now let's get into our diagnosis. And let me get my ICD-10. And it's actually going to give me some coding for 2017 because it's after October 1st. So do not actually pay attention to the coding if it's different than what you see in your book. It's possibly going to be the same, but if it's different, then just know that I have 2017 and you're going to be looking at a 2016. Okay, so I said that the patient had neoplasm. That's my main search term. And then for this book, it wants me to give the location of the neoplasm, because on the table, you know, the word neoplasm is everything related to neoplasm on your table. However, the table is divided in alphabetic order by body part. So let me put here vocal cord. Let's see if I can. Let's see. Next. It's taken a long time to load. I think my system may be going down, so it may not let me pull that code. It's a lot to load, so just bear with me. Okay, so I was able to pull my neoplasm for my vocal cords, and as you can see, there's true vocal cord and there's false vocal cord. So that does matter in your code selection. As you can see, as we mentioned, the table has primary, secondary, in situ, benign, uncertain behavior, and unspecified. The provider gave the patient a diagnosis of primary. So what it does here in the tabular, because remember, you're on the table, but you always want to review your tabular list. Okay, so it says C32.0 is my category, or C32 is my 3-digit category. So your 3-digit category has a lot of other codes underneath here, okay, that you want to pay attention to. And as you can see, it's giving C32 is for the larynx. This is talking about the glottis. This is talking about the supraglottis, and then it's telling you what's included in here, okay? And as you can see, you have the word false vocal cord, and you need to find the code for true vocal cord. Okay, so this is malignant neoplasm of vocal cord true. It's giving you this code here, and this is a freebie. And so I am adding this code, or I think I added it, but you also have, you know, notes and things like that that you need to pay attention to. And I'm going to click on what my edits say right here. Now, this is something that you may not have access to, but the reason that I said earlier is that you have to code for the tobacco or history of tobacco dependence or something in that category is because you have to, it says here, these are your clinical, you know, you're doing real coding, They want to know if this diagnosis was caused by something the patient did in their life. So you have exposure to tobacco smoke, environmental, occupational, and perinatal period. Are they tobacco dependent? Right now he isn't. It says the patient quit. Or does he use it? Is he currently using it? Or does he have a history? So if he has a history, then that is what you would code for. So we have pretty much summarized this entire, go back to my book. We have pretty much summarized this entire coding exam. And so this is just a real good way for you to process your coding exams in the future. Remember, you're going to have different sections of your, and let me see 1 second before I go, because I was just about to go. You're going to have different sections of your test, your abstracting portion. As you answer those questions, you're going to become more and more familiar with what you're doing as a coder. Surgical procedure, anything related to the CPT, your diagnosis, your ICD-10, what we just discussed and what we went through, and then assigning codes. As you answer portions 1, 2, and 3, you're going to come up with your answers for portion 4. So that's pretty much how it works, and it's really easy, it's really fun. So don't hesitate to reach out to me with questions during the week. Thank you for viewing. My phone number is 805-824-0065. Thank you. Have a great evening. Bye-bye.